On today's episode of the Pursuit of Health podcast, I was thrilled to at last sit down with one of my favorite people, Meghan Kelly. She's the director of the Child Life program at the Children's Hospital of Montefiore in the Bronx. I've worked with her, caring for patients together for several years, and I've always wanted to sit down and spend some focused time discussing her specialty of child life, as well as pick her brain about the implications for our U.S. healthcare system at large. Typical of our discussions, it went on for some time, and we therefore decided to break this talk into 2 episodes, now part 1, and we'll come back in a week for part 2. During part 1, we talked about the history of child life and her own personal journey along the way. We went through the nuts and bolts of education to become a child life specialist for those who are interested in the field, which has now become a very attractive, highly specialized, and competitive field. We've talked about the valuable role of child life in clinical care through the stories of some of our most empowered and memorable patients. We then focus on the gaps in child life. What are the current challenges that are holding us back? And the need to be creative financially in order for us to get child life services to the people that need it, in this healthcare system in particular. We then finished this first episode with discussing the transition from inpatient to outpatient care and the role that child life plays there. So sit back now, relax, and join us for our discussion with Meghan Kelly of the Child Life program at Montefiore. Okay. Well, it's really exciting to take the conversation we had on a telephone, Meghan, and take it to this forum and really sit down and have a discussion, because I really enjoy many of our discussions together, and I kind of missed the times we stopped by. I stopped by and knocked on your door and said, "Can you talk for a minute?" And that would end up being at least half an hour, if not longer. I can't believe that's almost 10 years ago that we were overlapping there.
Wow.
And I think it's a testament to our shared commitment to children that we keep these conversations going, even though we're not working at the same place. So welcome very much, Meghan Kelly, who is the director of the Child Life Patient and Family Programs at the Children's Hospital at Montefiore. We're really honored to have this discussion with you today. And what I really wanted to review for everyone, I think I first remember my experience with Child Life when I was a resident, and I really didn't know what that was. And I quickly learned to be not just dependent on it, but to rely on Child Life when I was training at Columbia. And I really found that for me, it filled in all the gaps. As I call it, it was the glue that binds, or the mortar that brought all the tiles together. And really, I can't think of doing healthcare for children in hospitals, or hopefully outside as well, without Child Life. So thank you for all you've done and joining us to talk about this. I understand there's a lot of history behind Child Life. It goes back into the 20s, and it really became more formalized in the 70s in many ways. But could you give us a little background into what Child Life was like, or what the life was like for a child who was in a hospital, who was chronically sick or for a prolonged period back in those days, and how Child Life has changed that?
Sure. Thank you so much for having me on today. I really appreciate the time to talk to you about this. As you said, we have so many conversations over the years about it. And, it's really great to have an opportunity to expand it a little bit in our conversation.
Absolutely.
And as you mentioned, Child Life started, back just after the turn of the century there in the 20s. And back then, the women that were involved in Child Life were really providing developmental stimulation and play opportunities for children, and helping them to continue to hit their milestones as they were moving through healthcare experiences. And, through the decades, healthcare has changed, as we know, and there have been different methods of how families are integrated into that healthcare experience for children. And I know that when I was a child, I was sick for 2 years. I was very sick with myasthenia gravis, and was in and out of the hospital a lot. And my parents were allowed to visit me, and they were allowed to bring me on appointments, but they were never invited to stay in a treatment room during a procedure or stay overnight at my bedside while I was sick. And that was very, very challenging for me as a young girl, to be left alone like that and not have my parents as advocates and support people for me in that setting.
That must have been a big
Sure.
impetus for you to you must have that in your mind constantly nowadays.
Well, it's funny because I didn't even know what child life was. And I went through my healthcare experience in a Manhattan hospital without any child life support.
Right.
Even though it was the 70s, it just wasn't that broadly used. And I didn't have any support in that way. And I didn't know one thing or the other about it. So I didn't even know what I was missing.
Right.
And I went on to become a special ed teacher after my studies at Boston College. And I taught special ed for 15 years. And when I came back from Boston to New York, I had a job as a teacher, and one of my colleagues knew that I was looking to pursue my master's degree. And she suggested that I check out Bank Street College because they had a master's in education and special ed, which is what I was doing.
Correct.
But they also had this program in child life. And I guess just in knowing me and talking with me, she thought this might be a good fit for me. So she said that I should go talk to her mentor and her advisor, who was Elizabeth Pfeiffer. And I went and spoke to her, and she's one of the pioneer women in the early child life days in New York City. And it was like full circle. It really made me feel like this is why that happened to me when I was younger, so I could understand this process and feel called to this work. And I went on to become a child life specialist and leave my career as a teacher, and worked for several years as a child life specialist at Montefiore after doing my internship there, before I took on the role of director, which was a hard decision for me because I really loved doing the clinical work with the children and families. But something in me knew that I could impact more change if I became an administrator and looked to build the program. And that's what ended up happening. We had only about 5 people on staff when I became the director in 2004. And now we have over 25 people in that program. And I also run several other programs at the hospital, including 2 mentorship programs for Bronx young adults that are bringing them into healthcare careers. So it was a little bit of a, twist and turn to find my way into this field. But I've now been at Montefiore for 21 years. And I've been able to accomplish a lot with my team. I've had amazing clinicians working on my team in child life. To become a child life specialist, you need to have either a bachelor's or a master's degree in a related field. It could be a child life degree, but it could also be psychology or child development or family studies or education.
Has that expanded? Is that the inroads to that field? Has that become more diverse, the different ways you can come into the field? Has that changed?
I would say that it was more diverse in the past. It was more of some people like me who had a degree already or who were pursuing a degree, and then they found child life and they did the other things necessary. But the criteria for what you need to do to become a child life specialist has developed over the past 10 years pretty significantly. As a previous board member of the Child Life Council, which is now called the Association of Child Life Professionals.
Right, you've taken many leadership roles.
We worked on developing standards that would lift our profession up. So in addition to the coursework and academic curriculum things that you need to do, which include those 10 specific courses in child life, you also need to do an internship for 600 hours under a certified child life specialist, and you need to take a certification exam. These days, there's so much of a competitive student body in this field that a lot of students are also doing practicums. The difference between a practicum and an internship is a practicum is really an observatory opportunity where you're observing a child life specialist. You're learning how to do observations and assessments. You're learning how to take notes succinctly on what you're observing and relate that to the child development background that you have so you can understand what it is you're observing and why a child life specialist might choose certain interventions for certain age children. And in that setting, you don't really do the work yourself. You're watching someone do it, and you're learning how to translate the theory that you know into the practice that the child life specialist is doing. When you do an internship, you're actually being trained in the clinical aspects and you're doing it yourself. You're learning how to teach a child about their diagnosis in the way that they'll understand. You're learning
is the practicum before the internship? Is that something that you always do first? Yes, the practicum would be before
the internship. Yes.
All right.
And it actually, these days, because it's so competitive, if you have a practicum, it gives you a little bit of a leg up in the application process for an internship.
Good.
If internship coordinators see that you have a practicum on your resume, you're going to have a little bit bonus in your opportunity to be selected for internships, because there are not enough internships in the country for the number of students we have entering the field right now.
That's wonderful, though, to see how that's grown. I mean, to be competitive. I mean, it must be.
It's extremely competitive now, and students are really trying everything they can to give themselves an edge in the competitive nature of it.
What do you think it is that draws people to that? Then you go from something wherein you had your own experience where you didn't even know what it was. Then you're an educator, and then you turn around and somebody says to you, "Hey, I think child life is good for you," and you say, "What's that?" To go to the point from that to a point where now it's competitive. That must be very fulfilling to see your field grow like that.
Absolutely. Yeah, I think a lot of people have similar stories. They either had their own healthcare experience, or maybe somebody in their family or a friend had a healthcare experience, and they observed that. And the more recent ones in the past couple of decades might have observed that child life piece.
Right.
And they were like, wait a minute, here's a career that combines education, healthcare, child development, and play, which is our main tool. We use play as our main tool for teaching these coping strategies and being able to go along with a child and use play techniques or guided imagery techniques, relaxation techniques to help them cope with a difficult procedure or a difficult intervention is very, very gratifying. So that there's a lot of people coming into the field. And I'll tell you, a couple of months ago, so there's a rule in the code of ethics in the child life counsel profession that says that you're not supposed to have a personal relationship with your patient until after they're 2 years out of treatment, right? So when I first was in the field, I was working with a lot of adolescents. And so now they're all in their 30s. And I can tell you that when they hit 21 and they were stopping treatment in the pediatric department and they were going in adults, and then when they hit 23, they all hit me up like, hey, Meghan, we know that rule. It's over now. We can connect with you. So I have a couple of people, young people from my past that are now, personal relationships with me. So one of them contacted me a couple of months ago, and she said, I want to send you a screenshot of a text message I just got from my cousin. And he's an African-American male living in Atlanta. And she said, she sent me the screenshot, and the screenshot was him sending her a text saying, guess what? I just passed my certification exam to become a child life specialist.
Oh my God. That's wonderful.
And she was like, woohoo. And he said, it's all because of you. I remember being at the Children's Hospital Montefiore with you when you were going through your cancer treatment. And I remember your child life specialist coming in every day to work with you. And that inspired me to become a child life specialist.
Well,
you can put two and two together and know that I was that child life specialist. And now we have this young man entering the field, which is amazing because we don't have a lot of men in our field and we don't have enough diversity in our field either. So we're always trying to engage young people in a diverse population to come into our field. So I was so pleased by that.
It's fantastic to watch that growth and to see something that I actually feel the absence when I go into any medical facility or hospital or otherwise, and I don't have child life around. I feel like there's something missing. And I think the people who haven't had that experience with child life don't know that they're missing that. And I think once they do, it's almost hard to let go of it. It's almost like if you have a child life presence in your facility, in your care network, you hold on to it. It becomes invaluable. And I really do feel that. And it must be wonderful because I think one of the first things I remember is the whole idea of the procedure room you're talking about and being involved in that and how it dramatically changed that whole experience for not just the child, but the family. And I think the caretakers, us as well as clinicians.
Absolutely.
When we're doing something that, we know is necessary, but has pain associated with it, to have that kind of presence around and change the dynamic for everything. Put the child back in control is what I saw you all do. Let the child be the center of that. I remember magically the idea of the child turning around and just reaching up before we did anything and said, hold on. I said, okay, you okay? And they said, yes. This little girl said, hold on. And she reached up and she went click. And I would, what was that all about? She goes, I just turned the button for pain off. And
I love that.
And I went,
I love that.
Where did you learn that? And she goes, my child life person. And I went,
Wow, that's
whoa.
amazing. You bring up such an important point, Eric, because we've talked about this earlier, and I teach all my students and all my staff that when you're a child life specialist, your goal is to teach the child and their family coping strategies for getting through challenging life events and healthcare experiences.
Absolutely.
Now, if the only way the child can do that is if I'm standing next to them, prompting them in their ear all the time,
right,
then I failed. I haven't hit my goal.
Right.
Because they need to be able to do it all the time. One of my favorite memories was of a boy that I met on CHAM 6 in the adolescent unit years ago. And he had a severe neuropathic pain disorder. And I went in to meet with him, and I have an expertise in guided imagery. Right. It's really the technique of self-hypnosis, but we use the term guided imagery in child life. And I went in to talk to him about it. And I said, I know this cool way that you can use your imagination to help you control your own pain. And,
Magic, yeah.
And we started talking about it. And I said, have you ever done anything like that before? And he said, oh, yeah, I went to this other hospital one time, and they had this special room with these lights and an aroma coming in, and special chair that you could sit in, and this lady would talk to me, and I would do that for a couple minutes, and it would be pretty good, And I said, okay, well, I do it a little differently here, so let's try it this way and see what you think. And I taught him how to do self-hypnosis. I taught him how to do it himself,
without all the bells and whistles,
without a chair,
right,
without a aroma, without lights, without anything special going on. Just your voice in your head, telling you how to control your pain perception. And he really took to it. And then the next admission, when I saw him, I said, are you still practicing that guided imagery? And how's that working for you? And he said, you know what? It's so much better than the first way I learned it, because the way you taught me, I can do it anywhere. Right. I can be on the subway and do it. I could be in a soccer game on the sideline and do it. I can be anywhere and do it. And I can control my own pain. And I thought, wow, what a success story. I've always carried that with me.
That's empowering. I mean, both for him and all the people he can share it with, but absolutely. I mean, you're talking about a legacy basically here now, where you go from a time when the parents weren't allowed in the hospitals. Imagine a child sitting during some of our prior pandemics, which we had in New York, and the child would be hospitalized. And they'd be sitting there sick or premature or all these other things, and the parent couldn't come in. We go from that to, okay, now we can have the parent come in. That's nice. But when there's a procedure, we don't need you there, mom and dad. You're somehow interfering. You get into that dynamic. It's like, really? And we think of that as, archaic now, but no, we need the family there. They're soothing, to the point where we're now not going to just bring the family in and have them be in the hospital and be in the procedure room, but we're going to bring the family in and teach them some skills. And then we're going to show them what our kid can do. And the magic of what a child can do when under hypnosis or whatever. And all of a sudden, all of us in the room are changed. And then you go to it, and what you've done is literally embodied that whole concept of life. You gave that child life again when they were sick. I mean, that's why I like the name. I mean, talking about branding today and things like that. You think of kid as sick, and in a hospital chronic time, you think of you're taking away their life, and you're saying, no, I'm giving it back. This is part of their life, and I'm going to empower them through this. That's magical, and I think that's a great
way that you've looked at that. I don't think I've ever heard anybody perceive the name Child Life in that way. That's great.
It just hits me. It's so simply clear, and to see it in practice has been wonderful, whether it's in the education that the kids continue to feel like they have a life in school. Here we are with, teleeducation and telehealth. I mean, Child Life was ahead of that a long time ago in combining all those concepts for somebody who was not able to be at home or in their school. So kudos to all of you on that. I mean, I think one of the things that you're always also very passionate about is making sure that everyone has access to it. You alluded to this, to the fact that it's grown to males, perhaps people of color as well, who are now playing a role in this. But I thought, we should also talk a little bit about some of our prior discussions about, is everyone able to get access to this? We don't see it in all the different places. We know that, Child Life. But have you seen any areas where this could be better, where there are perhaps gaps, whether it has to do with resources, whether it has to do with access for other sorts of disparities, socioeconomic, racial, other things? Because I'd like your point of view on that as we enter this and come live through this pandemic now, what is your thoughts about how child life has not only where it's come, but is it where it should be everywhere? And what are some of the things that might be holding it back?
So, wow, I have a lot of answers to that. So I will say, first of all, that I think child life has come a long way, and we are standard care in most hospitals now. The American Academy of Pediatrics came out with a position statement that was written in conjunction with some of the leaders in the child life field, which recommends that child life be offered as a service as part of the medical team's provision of care for all pediatric patients. And it's interesting because oftentimes when we go in to introduce our services to parents, they'll say to us, well, how much does this cost? Like they think they have to pay for it separately.
Wow.
And then we explain to them, no, we're part of the medical team. You're not going to have to pay for anything extra for this. Now, the interesting piece to that is that child life in our healthcare system is not reimbursable. So there's no way for the hospital to bill for the services that we're providing. So all of our salaries, all of our fringe benefits, all of our teaching tools, our toys, our puppets, our medical, kits, all the things that we use are not being reimbursed with any money from the Medicaid system or private insurance. So the hospital has to really rally behind our program and, number one, put part of our operating expenses on the budget, which at my hospital, all of our salaries and fringe benefits and basic operating costs are on the budget. And then we rely heavily on our work together with the development team to write grants and look for funders who will provide the programming and all the supplies and all the tools that we use.
I believe in your leadership role, you've spent a lot of time with that aspect of raising funds and awareness. So
well, I was very fortunate because I was a child life specialist when our CEO, Dr. Philip Oswa, wasn't attending on the floor.
Absolutely.
So we used to work elbow to elbow. So he's very familiar with child life the same way you are and is a great supporter. And then, our executive vice president, Dr. Peter Semchek, who oversees our campus, is very familiar and a huge supporter. And my current, direct boss, Tara Buckemeyer, who's the assistant vice president for nursing in CHAM, is a huge, rallying factor for child life. So we have a lot of support at the hospital. The challenge is the funding piece of it. And one of the things that the Association of Child Life Professionals, ACLP, is doing is really trying to promote research in the area because there are actual studies that can show that there's financial gain to having child life.
Absolutely.
And some of these studies have helped me to get additional positions. So, for example, if you have a child life specialist in a radiology department, it's going to make a huge impact because if you don't have child life, what do you have to do when a child's going for an MRI? You probably have to sedate them. So that's going to require an anesthesiologist, a regular physician, a nurse, the technician, the person who's going to get everything ready in the room.
Medication costs,
and that,
IV costs,
when we looked at that, looked at that in terms of funding.
Absolutely.
That came out to be like $920 an hour of salary. And then plus on top of that, the medication, the risk that the medication poses to the child. And the time of the intervention. If you have to prep a child for anesthesia and then do the imaging and then let them wake up from the anesthesia, that's a much longer study. Wow. So if you just added one child life specialist into that mix, all those other people are out and you just have the technician, the radiology technician and the child life specialist. That brings it down to about $120 an hour.
That's amazing.
And then you're down to about 45-minute imaging study rather than an hour and a half.
And the quality of the study is 10 times better.
In the length of a day, you could get 10 patients on the table instead of 6. So that's all bottom line numbers. If you do all that math out, you end up with more income for that because you're still getting reimbursed for that procedure, but you're not spending all that money on all those extra people and the medicine and the quality of experience for the child. So those kinds of that kind of data has allowed me to start positions in areas like radiology where we didn't have them before. And that loops me back to part of your original question, which is, where do we need more child life? So when you think about it, and I pose this question to you, where do you think are the two places that children have their first healthcare experience? I'm talking about areas of the hospital. What two areas of the hospital do children have their first healthcare experience?
Absolutely. The emergency room.
The emergency room.
Okay. And
a phlebotomy suite.
That's right.
Right?
Yeah.
They're either going through the emergency room or they're going to an outpatient clinic and getting blood drawn somewhere.
Right. The scary places.
Those are probably two of the most traumatic experiences to have. And yet, historically, when you look around at child life programs all around the country, including Montefiore, we have less staffing in the outpatient areas than we do in the inpatient areas. That's a big issue that we need to find more funding to build up those areas. There are child life specialist programs around the country that have round-the-clock coverage in their emergency room, the same way the doctors and nurses are there around the clock. Child life is there around the clock.
Wonderful.
And some of them have gotten very creative in finding ways to use their billing system so that when a child comes in, they triage them and they determine different levels of care that are necessary, which get coded into higher billing rates. And part of that coding has to do with, did they add in the layer of child life? If they needed the child life specialist because it was a suture or it was a invasive procedure, whatever it was, if they added in that layer of child life, it bumps them up to the next level of billing. And then they're able to generate more revenue, which then pays off for the child life specialist.
And you have to track
and a better experience.
Yeah. And you have to track all that. And it's amazing because in children in general, Meghan, we think of them as needing to be more and more less in the hospital and do a lot more things in the outpatient setting. And so we kind of have to bring and drag that hospital-based service, that we had, that whole network, and put it into the outpatient setting too. We can't, it's kind of like it's kind of, I see like somebody who ran ahead into the outpatient setting and like there's a whole team that never followed right on their tail. It took a while to get all into that. Yet we're pushing for that. We're pushing for all of this care to be done closer to home in the outpatient setting, not having children there. The whole entire dynamic of sick children is to be in the hospital as little as possible, get home, back to those environments, and your services and child life being part of that life for them doesn't mean they suddenly are now not sick or not feeling these things. It's just because they're not in those four walls of the hospital. So now that they're in the other settings, that's wonderful. And I think that's where health...
That is exactly right. When I started there 21 years ago, a lot of the treatments that children were having were done inpatient. Chemotherapy was done inpatient. A lot of these kinds of things were done inpatient. And that's where we focused our staffing. Right. But now a lot of that is done outpatient. I mean, you have to be very, very sick to actually get admitted to the hospital these days.
Right.
If they can treat you outpatient, they will, because it's better for you. It's better for you to be out of the hospital and at home recovering, so if there's a way to do that, that's what we do. But we need to focus more services for child life in those areas.
Absolutely. And the whole idea of looking at quality, using that label, we want quality, we want value. Children are the definition of that, how we've approached that. And to have a service that integrates everything together to make sure that you do that, like you said, when you could eliminate, and not in a negative way, eliminate all the other layer of things that was not necessarily helping, and simplify things. It's always better to have 2 or 3 people having a discussion about how to manage something than 20. We just know that you get 10 physicians in a room, you got 100 different opinions. Here you are, you took that radiology procedure and simplified it and created a core team who knows how they think. They can read each other's minds. It just changes the whole dynamic for that child. They feel, and the family feels, these people got it, versus, okay, we've got one person who's not quite getting it on this team. And, now it just disrupts the whole dynamic. I think that's wonderful. And that's really a value-based thing. I hope you all enjoyed our time with Meghan Kelly. We learned about the valuable role and evolution of this little-known specialty, child life, that has had a major impact on the health of sick children. We learned how her team has overcome the economic challenges facing them as they strove to provide their services to children and families too often left behind in our current healthcare environment. On our next episode, we'll continue part 2 of our discussion with Meghan Kelly, where we will dive deeper into areas such as implicit bias and disparities in access to care. Until then, I'm your host, Dr. Eric Fethke, wishing you success now in all your pursuits.